So I'll close where I started around evidence to action. This is not a new idea. In the 6th century, Abu Bakr said, without knowledge, action is useless, and knowledge without action is futile. And I think that's the best introduction to the panel that we have assembled today, because my colleagues and my friends who are going to be joining us are all about both knowledge and action. It's a really, as much as a privilege as it was to introduce you this morning, Dr. Dietz, it's as likely a privilege to introduce Rafael Perez-Escamilla, Marlene Schwartz, and Gretchen Van Wy. I have a personal relationship with each of them, and so it's just, I'm a little overwhelmed, a little speechless, and those of you who know me, I'm not that speechless very often. Dr. Perez, I'm going to introduce each of them briefly. Their bios are on the back, and many of you know them from the work which precedes us today. And they're each going to speak for about 12 minutes, and then we're going to bring the three of them, along with Dr. Dietz. We'll have a panel discussion. I'll probably softball the first question out, and then we'll really open it up. And we want to keep it quite interactive up through the lunch hour. We'll break for lunch, have more opportunity to network, the awards, and so forth. So, Dr. Perez-Escamilla is Professor of Epidemiology and Public Health and the Director of our Office of Community Health at the Yale School of Public Health. And we were delighted to recruit him from University of Connecticut already 3 years ago. And among his many achievements, he is currently the chair-elect of the International Nutrition Council and the chair of the Minority Affairs Committee of the American Society of Nutrition. Dr. Marlene Schwartz is the Deputy Director of the Red Center for Food Policy and Obesity at Yale, and though we can't claim her as one of our alums, is an alum of Yale University, obtaining her PhD in psychology in 1996, and we always can't help but reflect. Marlene was a graduate student when I was a postdoc, so we've known each other for, it keeps getting more, 20 years. And again, among the many accomplishments, Marlene is co-chaired the Connecticut Obesity Task Force in 2010 and provided expert testimony for state and federal policy. She's featured in HBO's Weight of the Nation. In fact, a friend of mine from California called me the other day and said, "Do you know Marlene Schwartz?" I said, "Yes, I'm having dinner with her tomorrow night." I think it's also notable that to think about not just the obesity epidemic, but the co-occurrence of hunger in our community. And with that, I'll mention that Marlene serves on the board of directors for the Connecticut Food Bank. And finally, Dr. Gretchen Van Wy is an alumna of the Yale School of Public Health, receiving her PhD in 2004. Gretchen is the Deputy Director for Chronic Disease Prevention in the Bureau of Chronic Disease Prevention and Tobacco Control in the New York City Department of Health and Mental Hygiene, and we will hear more about the sodas. She did say in response to your comment, you can get your 16-ounce soda, you just can't get the 17-ounce one. And we're going to hear a lot more about that, and I'm pleased to have called and humbled to have called Gretchen a student and former teaching fellow, and so we're delighted. Welcome home to you. So with that, let me pull up, let's see.
Thank you so much for your kind introduction, Jeanette, and what a privilege and a pleasure to be participating as part of this panel. Before I get started, I just want to acknowledge three members from the Office of Community Health that are here with us, Elaine O'Keefe, Marianne Boss, and Kathy Trout, which they do wonderful work for the school and I know for the communities and all of you as well. What I'm going to talk about is the life course framework for overcoming childhood obesity and how I have applied it in my own community-based research and program support work. Minority women of reproductive age are more likely to be overweight or obese compared to their white counterparts. And the same pattern can be detected beginning very, very early on in life among minority children. So a very important question is if is this just a coincidence, or if there is indeed a relationship or a connection between maternal and childhood obesity. A substantial level of evidence presented in major scientific and evidence-based public reports suggests that there is indeed such a relationship that can be summarized through the following two cycles. Cycle A, which refers to the mom or the first generation cycle, and cycle B in relationship to the child or second generation cycle. If we assume that a mother is becoming pregnant at a time when she is overweight, this increases the risk that she is going to gain weight excessively during pregnancy in relationship to the IOM recommendations, and it also increases the risk that the mom is going to retain excessive weight postpartum. As a result, when mom becomes pregnant again, she's going to be even more overweight or obese in relationship to the previous pregnancy. Because minority women, in relationship to their fertility patterns, have more pregnancies, have more babies than their white counterparts, this may explain, at least in part, why they also are an increased risk of being overweight or obese. Now, with relationship to the child or the offspring, what cycle B tells us is that moms who are overweight or obese before becoming pregnant, who gain excessive weight during gestation, are more likely to deliver offspring or babies that have a neonatal predisposition to themselves becoming overweight or obese. And this vulnerability becomes especially acutely expressed if the babies are not breastfed exclusively for the first 6 months of life, if they are introduced to unhealthy complementary foods and beverages that lead to an excessive weight gain during the first 6 months of life. That is also going to increase the risk that the child will be overweight or obese by the time becomes a preschooler, and then if things continue going the wrong way, also when the child becomes a schooler, a teenager, and by the time we have an obese teenager, the likelihood that this individual is going to remain obese as adult is incredibly high. If we're talking about a girl, then that is going to be about the age when moms may start the children, youth, adolescent, and then young adult mom is more likely to start having her own children. So then we can see the cycle B merging with cycle A. And I think that these cycles are very useful, although there are still a lot of knowledge gaps. They're very useful for trying to understand why the life course approach is so important for addressing the childhood obesity epidemic. Waiting until the kids go to school to start with actions is going to be too late for many kids who are already epigenetically programmed to become obese. When we talk about the reasons why minority children are much more likely to be overweight or obese beginning very, very early on in life, the work of Elsie Taveras and colleagues at Harvard in relationship to the VIVA study is a very important one to share with you. What they did was to look at practically all the known risk factors for childhood obesity and see if minority kids were at higher risk of being exposed to those risk factors in relationship to their white counterparts. The red circles, what they tell you is that for these risk factors, for the great majority of them, indeed, there is an increased risk for minority children and or their caregivers to be exposed to them, beginning with antenatal depression, very fast weight gain during the first 6 months of life, lack of exclusive breastfeeding, introduction to complementary foods before 4 months of life, a maternal infant feeding style that is restrictive and that puts a lot of pressure on the child to eat a lot of food. Obviously, what has become of a lot of interest to many of us, lack of enough sleep. Minority kids are more likely to not have enough sleep as early as 6 months to 2 years of life. They are more likely to have a television in their bedrooms at 4 years of age, to be consuming sugar-sweetened beverages at 2 years, and to be consuming fast food at 3 years. So I think this work is very helpful for understanding the multiple risk factors that minority kids are being exposed at a much higher rate than their better off counterparts. That in part may explain also why their rates of obesity are greater. So in 1995, I led a needs assessment in Hartford in partnership with a wonderful community-based organization called the Hispanic Health Council. And what we did through this needs assessment was first to assess the nutrition and food situation of preschooler Hispanic children, mostly Puerto Rican preschoolers who were on average 3 years of age. What we documented since 1997 was that there were many major problems related to the food and nutrition security of kids in this community starting at a very early young age. There were very low rates of breastfeeding. Breastfeeding duration was very short. There were many undesirable practices related to the very early introduction of complementary foods, adding cereals to the milk and give it that together with a bottle at a very young age. Very, very low intake of fruits and vegetables, very high intakes of sugar-sweetened beverages, a lot of hours of television viewing per week, a very high level of food insecurity in the households where the kids lived, and about 20% of these 3-year-olds were overweight or obese. Once we completed that needs assessment, because we had identified a funding opportunity to develop a nutrition education program, we also conducted research on nutrition education needs in elementary schools, the public elementary schools in Hartford, by doing a study, survey study with the elementary school teachers, and we also conducted a community survey similar to the one that Jeanette just described for New Haven, specifically focusing on the food, nutrition, knowledge, attitudes, and behaviors of the caregivers of young children. We had a sample size of 500 households. What we did with all of this information in very, very close partnership with the Hispanic Health Council was to develop the architecture for a community nutrition education program that, as you can see, keeping to the spirit of my talk, has kept pretty much with the spirit of the life cycle approach for childhood obesity prevention. The program has included social marketing campaigns, such as the Salud campaign, where we hired a marketing firm in West Hartford, who then got in touch with Latino TV celebrities who agreed to appear for free, their image to appear for free on the Salud campaign, where they were toasting to your health with fruits and vegetables. And hopefully, we were able to target very well women of reproductive age through this campaign. We have also developed a number of prenatal nutrition education materials and curriculums based on what I think is very interesting community-based participatory research. But perhaps my favorite piece to share with you about is a wonderful breastfeeding work that we have done together in the community with Hartford Hospital as well. We have a breastfeeding peer counseling program that was developed by Grace Damio from the Hispanic Health Council almost 30 years ago. And what we did was able to strengthen it, and as you will see in a moment, to build the evidence to understand if it worked or not. We also delivered a social marketing campaign addressing the support that women need from those individuals who surround them for them to be able to breastfeed successfully. And we developed a very culturally competent and innovative and fun materials for the women to, and their loved ones to understand the importance of breastfeeding and the availability of support for them to do so through a very nicely illustrated photonovela, which is sort of the print version of a soap opera. And Latinos and Latinas love it. We have also done work with the WIC program in Hartford, developing an infant feeding guide addressing complementary feeding issues. And another of our favorite products are the wonderful PANA puppet shows that are delivered through elementary schools now in 7 cities or towns throughout Connecticut. It's a series of 6 puppet shows dealing with different topics related to heart disease prevention, diabetes prevention, Farmer Fernando, where the food comes from, food safety, physical activity, and so on. We have thousands of children contact hours per year from preschool all the way to 4th grade through this program. And for many children, this is the only good quality nutrition education that they're getting in the schools. So what also I wanted to emphasize is that the evidence that has been used to build this work has not only been instrumental in developing the campaign's curriculums materials, but it has also been instrumental in persuading extramural agencies to fund intervention research for our group. And the best example that I can give you related to our breastfeeding peer counseling research, thanks to the generosity of the CDC and the Donahue Foundation, we have already conducted 3 randomized community trials demonstrating the effectiveness and the efficacy of the Breastfeeding Heritage and Pride program, as our breastfeeding peer counseling program is known. And through this research, we have also been able to show how difficult it is for Latinas who are obese to breastfeed. It is a very challenging issue that we have conducted a randomized trial with the Donahue Foundation support that is currently under review. Now, the Breastfeeding Heritage and Pride program has now been replicated at the Yale New Haven Hospital, so there has been the dissemination, and in fact is highlighted in the IOM Weight of the Nation report as a best practices community-based initiative to promote breastfeeding. So we feel very proud of these accomplishments, but what makes me feel the proudest of everything is that I directed this program from 1995 to 2009. The University of Connecticut was the lead agency conducting, directing, receiving the main funding for this program. Since 2009, the Hispanic Health Council became the lead. The Hispanic Health Council has been fully empowered to take on the task and continue it for, hopefully, for many years to come. Now, as we were discussing last night at dinner, I happen to feel very strongly that both education and individual level behavior change interventions are very, very important for addressing the childhood obesity epidemic, but obviously it's not enough. It is a necessary but not a sufficient condition. And things are not going to change, as Dr. Dietz said, unless we fully address the major policy and environment systems issues that are affecting the access to food, physical activity, and other lifestyles among women of reproductive age and their young children. And I'm not going to say much about that because myself, I have not done a lot of that level of research at that societal level, but the speakers that will follow me are going to be addressing very nicely several of these issues. Also, as you can see, there have been a number of recent publications from our group and other groups making some very specific recommendations, for example, as to how to improve the coordination among maternal child programs that oftentimes serve the same moms but have absolutely no communication with each other and are not being consistent on even the key educational messages that they are given. In the book that I co-edited and published last year with a colleague from Ohio State, we present the very important case that with Latinos, as it happens with any ethnic group in the country, it is very important to be culturally sensitive and to use culturally appropriate and income appropriate models such as community health workers that can help bridge the gap between the clinical-based and the community-based care that is needed to make the systems change work at that level. So where are we? I think where we are is with a big problem, because this is a very complicated message to send in a way that everybody understands it out there. I think we need to engage much more, first of all, in learning how to frame the life course message to affected individuals, to communities, to policymakers, and to all the key stakeholders that need to be a part of these solutions. And I would argue that a very, very important first step is to actually have a report of very high visibility that integrates the knowledge that is very fragmented right now in different reports and puts it together in a single policy document. And I would argue that perhaps the best document to do this are the dietary guidelines for Americans, and this could be a very nice challenge that we could assign to that committee to see if they can take it on. I strongly propose the development of a national life course indicator, which obviously has to be multidimensional, reflecting every single component of the life course approach. I think on the one hand, it is a lot of stuff that the indicator has. On the other hand, the values, the baseline would be so low that it wouldn't take very long to make it work a little bit soon. And I want to end my presentation with the picture of the daughter of one of my favorite former doctoral students, Angela Bermudez Millan, who did her study on dietary intakes of pregnant Latinas in Hartford. This is her daughter on the right-hand side when she was about 2 years old, and on the left-hand side is when she was sound asleep as a baby, and I don't know if you can see it, but she has mama's milk dripping from her mouth. And obviously she was sleeping enough hours. So I think that at the end of the day, what we want to make sure is to maximize the chances that all the kids in the country have the opportunity that Angela's daughter had. Thank you very much.